All right. Sorry. I temporarily forgot how to launch a slide presentation. All right, we are here. All right. Oh, I'm seeing the chat box. Oh, wonderful presentation. Thanks, Liz. I appreciate the positive feedback. So this is a case I was actually just briefly discussing with Dr. Edwards yesterday that I think we need some help with. So this is actually one of our young men who we've known for a long time, right? At least almost 10 years now. He's a 25-year-old male. He's perennially infected with HIV. Actually, what happened? He was diagnosed in 2003, and he was infected via breastfeeding because his mother was not tested in pregnancy, because she would have been she would have been pregnant in the late 90s, and the coverage of routine testing in pregnancy was not as uniform as it was back then. So unfortunately, she was not diagnosed in pregnancy. She breastfed, and when she became ill, her 2 children, 23 children, tested positive, and the husband tested positive as well. So he would have been diagnosed in 2003. Started treatment initially in 2005, and some of these drugs that you may not know. So nelfinivir is a very old drug that would have been around back then. So it would have been started on lamivudine, zidovudine, nelfinivir, started in 2005. But he was not well adhered to treatment, and to a certain extent, it's easy to understand why. Because if some of you who remember, nelfinivir was 10 pills a day, right? 5 tablets, the size of almost like one of those body symptom Panadol. Yeah, 10 of those. So imagine you're 7 or 8, and after 10 of those, 2 lamivudine, 2 zidovudine, so 12 pills a day. Yeah, it wasn't well adherent, and we can understand why as the aging of the child. So he was switched in 2007 because of treatment failure to lamivudine, zidovudine, lopinavir, tonavir, which was Calitra. And he was on that combination for about 3 years, between 2007 to 2010. Again, his adherence was not good. And a big part of the reason for his poor adherence was because his mother was poorly adherent. And his mother did not impress upon him the need to be adherent. And actually, when he came across this in 2013, that was the first thing he said. Well, if I only knew I had to take a medication every day, I would. Right? Because he was a little bit mature beyond his years. So in 2009, actually, the pediatric department reached out to us at Mrftt and we did a resistance test because he had virologic feeling, was not suppressing, despite the fact he was on antiretroviral therapy for 4 to 5 years already. So this is the resistance test and the mutations here, but I think the news is this part where, it has high level resistance to all these drugs in the left, intermediate resistance to one of them. And already at that age, high level resistance to lopinavir, tonavir, which is Calitra, high level resistance to zanavir, intermediate resistance to darunavir. Now, darunavir is kind of the big gun among the protease inhibitors, and he already was not fully sensitive to those. He did, however, have good susceptibility to drugs in this side here, on the right side, non-nucleoside reverse transcriptase inhibitors. So on the basis of this resistance, he was switched to efavirenz, to which he's sensitive. Tenofovir plus abacavir. Essentially, I think they were trying to put him on the most active regimen they could put him on, given the limitations. Now, he would have been placed on that from 2010 to 2013. And in 2013, December, he came across at about the age of 15, 16. He came accompanied by his father because his mother had died 5 years previously. And his father was actually on medication while adherent to his antiretroviral, injectable viral. Problem was he was hypertensive and not well adherent to his hypertensive meds. And that would come to haunt him later on. But the young man's CD4 count was 42. His viral load was almost 15,000. This was in December. We repeated the resistance test. And what it showed is similar resistance to all these drugs here, baclofen, zydophilin, Mrftt, tenofovir. But what had developed now is that he became resistant to efavirenz. He had some resistance to something called traveline. He still had intermediate resistance to the darunavir. So we chose to put him on a regimen of etraveline because he had some sensitivity there. Darunavir, ritonavir, because of intermediate resistance, and raltegravir because he had never been placed on raltegravir before, so expected to be sensitive. Now, he was initially well adherent between about 2014 to 2015, which you can see here. And he suppressed the injectable viral loads for about a year and a half. He had no family members aware of his status, so they were all supportive. But he was lost of follow-up between 2015 until 2017. And when he returned to care, he reported he was busy with schoolwork. He also reported his father had passed away a week previous to his returning into care. At this point in time, his viral loads were, low double digits. CD4 was low double digits, viral loads, almost 50,000. And he would continue to have a pattern of intermittent adherence. So he would return to care. So, for example, 2018, returned to care. By 2017, returned to care. By mid-2018, it's undetectable with CD4 counts up over 100. Then he would become lots of follow-up and would usually say, he's busy with school or later on with work. Sometimes he'd say he has some stressful situation that he really didn't want to talk about. Or sometimes he said he got tired of taking all his tablets and he's trying herbs instead. So he would come in and out of care, restart treatment, suppress, default, rebound, stop a treatment, suppress, get undetectable, default, rebound. So it was between 2018 and about 2021, there's an up and down, we just see with both his viral loads and CD4 counts. So he would go up when he's on medication, go back down when he's not. And when we repeated the resistance test, it wasn't because he had new mutations, it was because he's just not being adherent to treatment. Now, he came to us last month, first of last month, after having not seen us since December of last year. His viral load in October was actually undetectable, right? He had fever and chills, abdominal pain, cough. His CD4 in September was 83 with a viral load over 200,000, which is his highest ever viral load at any point in his care in the last decade. His liver was enlarged. He had some query, partial collapse of one lung. His urine was cloudy and had a white cell protein and blood in it. So we treated him as possible kidney or bladder infection with levofloxacin. I was suspicious of a fungal infection based on his symptoms, so I started him on itraconazole. Started back his treatment, but because he was poorly adherent in between, I wasn't confident that either etraveline or raltegravir were fully active, so I added tenofovir, Truvadis' regimen. He grew E. coli in his urine, which would have been covered by levofloxacin. We did a histoplasma antigen for fungus, and he was positive. So he was covered for everything, but despite that, he had to go back to hospital because he had persistent fever, chills, and cough. At hospital, there's a CT that showed enlargement of liver and spleen. He had a micronodular pattern in his lungs that was suggestive of miliary tuberculosis, and a lesion in his left lower lobe of his left lung, and a small pleural effusion. We weren't quite sure what it was. And there's a urine test you can do for tuberculosis, and it was strongly positive. So they actually called us to refer him to chest clinic to start him on TB treatment. So in summary, we have a perinatally infected young man with a history of poor adherence on a third-line regimen consisting of etraveline, raltegravir, and darunavir, ritonavir. Resistance testing shows he has no fully active drugs, other than raltegravir, and that may not be fully active either. He was intermittently adherent to treatment. His CD4 count most recently is 83 with a viral over 200,000. And he presented with active OI symptoms in September. He tested positive for both histoplasma and tuberculosis. So the question is how we manage his infections, because the headache that is going to come is all the drug interactions between his antiretrovirals, his antifungals, and his TB medications. And the second question is what do we need to do? How do we need to change our approach to try and retain him in care? Because he's been sort of falling in and out of care, staying going. Can't seem to hold on to him for more than a year at a time. And the periods of time are getting shorter and shorter. What do we need to do? How do we change our approach to retaining him in care? And I forgot to mention one thing in the presentation. His father had passed, in 2017. So right now both parents had passed, and he's living with his aunt and his nephews. And that's the presentation. I open the floor for any clarifying questions or any suggestions, because I think we are in dire need of advice, because he's a young man, a very pleasant young man, but he's in a very dangerous trajectory. If we don't get it right, he might not be on a sustainable path into the future. I will leave it open to any comments or questions. I see Conrad, you raised your hand.
Yes, I wonder if he's had any kind of introduction to any kind of PLHIV mentors or other peers so that he has someone to kind of talk to during those periods when he's thinking about dropping off.
So we had invited him to the youth clinic on a Saturday when he had returned to care and was a bit more consistent after 2017, 2018. Problem is that he was working every single Saturday. So at the time the youth clinic was going on, he was working. And more recently, he was actually working in Tobago. And that's why we didn't see him for 7-8 months. Despite the fact that the last time he worked in Tobago, we told him we will send the meds to you, just let us know. But Saturdays have not been, the youth clinic was not an option. He has never been linked to a pair like a buddy system or something like that. So that might be something we can consider moving forward.
Okay, thanks.
I wonder if I can ask either of these social workers who are here with us, Abigail or Maria. In your experience, is there anything that you think we could try differently? Because we would have seen a social worker, we haven't tried psychologists as yet, so I don't know if that's a possible option.
I would like to probe his social support. Does he live alone?
No, he lives with family, right? And they're all aware of his status, supportive. So he could send someone to pick up his meds if he had to, so you don't know. So this is nice.
Was the social work intervention continuous? Did he have more than one session with the social worker?
He did. So because he's been lots of focus on so many occasions, every time he comes back, we try to have him see the social worker. Sometimes I think he tries to duck out before he sees the social worker. Try to assist.
Oh.
Last time he didn't because he was having chills and rigors. He was supposed to come 2 weeks before the plans were stuff about that.
And is there any history of mental illness?
No family history, no personal history.
Okay.
He has
substance abuse? Any substance abuse?
He is, well-adjusted, soft-spoken, articulate. He has a girlfriend. He's disclosed his girlfriend. He doesn't drink, he doesn't smoke anything. He has a steady job. He's actually good friends with the CEO. So when the manager was asked about this work, he's staying home from work too long. He just phone call to see you. When you come back out, the job they're waiting for. So he's stable in so many dimensions. But this part is not conforming to that, that stability.
So, Dr. Boyce, you articulated the fact that he lost both parents and he was never socialized into adhering. So the same diagnosis that his parents died of, he is now dealing with the reality. So sometimes when a client have prolonged grief, they start to internalize their own mortality. And sometimes it goes across to being a psychiatric issue. In other words, like, there's no need for me to live. I didn't ask for this. This came upon me as a child, and they died, and this is just a matter of time before I die. So there's no value for living. So sometimes a whole personality change you might see in him. Okay, I could understand if somebody having to leave Trinidad and go to Tobago to work, and will have some complications in getting the meds and stuff. But he's not making a way. He's not meeting us halfway. So, not adhering for so long, there is no desire, no innate desire to live. I think the next step could be to refer him to the psychologist, but he needs to sit face to face, not online, not a telecounseling. He need to sit with somebody and understand, and probably trace him from the early childhood. What was the unresolved issues there, because it's most unfortunate that there's a correlation between children who were born positive and suicidal attempts. We see it all the time in the clinic, that they feel that this was just thrusted upon them. We see it with the kids at the home. So sometimes they just give in. They reach a point where they just give in to the virus. So I think now, if after they had explored social work intervention, they could explore psychological, a psychologist intervention. That's just my take on it right now.
Okay. Thank you. That's very helpful. Thank you. I appreciate that.
Most welcome.
Dr. Boyce?
Yes, Abigail?
Can you hear me?
I am, yes.
Just to add to what Maria is saying, because I was thinking along the same line, we have to remember that during his childhood, his adherence wasn't as well either. So he learned that behavior, which apparently continued throughout his adult adherence. So maybe a bit of the mindset, restructuring his mindset when it comes to adherence may be needed. And definitely the psychologist might be one of the better persons to deal with that. So we can consider that. One of the other things I always consider in situations like that, because we always find that there are persons who have difficulties getting to clinic, working long hours, going to school and all of that. Unless we think about community involvement and reaching them where they are, we're not going to find a way to change that for a long time. We have to consider reaching the patients in the community somewhere along the line. Because I know we do the post, we send out via TT posts for some persons, but we, for some reason or the other, we are missing because we are not taking it to the community at all, and those persons are not being reached. They continue to miss and be non-adherent, and they have nobody to really talk to when you send a TT post.
Right. Thanks for that, Abigail.
Okay.
Any thoughts, Dr. Edwards, about how we manage this TB diagnosis? Because it's based on the CT findings as well as the with TB blood tests? Because I mean, we had this question before about 2 or 3 different cases. I don't think we ever got a good resolution as to what to do. If it's a TB histo co-diagnosis, the last patient who had it was, both a TB diagnosis and a isoplasma diagnosis. We just treated the TB first because he wasn't ill for histo and he was improving. So, this young man is, much more ill than that. So I don't think we can afford to not treat his histo while we treat his TB.
I know all the drug interactions as the issue, that itraconazole interacts with the rifampicin, so difficult to treat. But wondering is the histo causing all the problems? Is TB anyway? So he has all the splenomegaly and hepatomegaly and stuff. So we probably have to treat both, but that's a difficult thing. No rifabutin, huh?
No rifabutin. I think the last rifabutin system was either early last year, and that had expired the previous year. So they haven't bought any in a while.
There used to have a warm line that you could reach out to people on. We don't have access to that again.
I checked that.
In the US.
Yeah.
You probably need some assistance with that one.
We mightn't be able to call them, but I think they still accept email submissions, because we should be probably still on their email listing. So I'll check and see, because I got an email from them some years ago. That's a possibility.
I think that may be the way to go.
All right. So I'll do that before the week is up. Okay, so I want to be mindful of time because it's just a minute after 3. So in terms of the recommendations for this case, we can explore his family support, think about introducing him to a peer buddy system, and including in that, as Abigail was saying, think about actual community involvement, whether there's a peer in the community or some other form of community support. Refer to psychologists to really unpack what is the psychological basis for the behavior we're seeing, and try to restructure his mindset in terms of his relationship to medication and adherence to medication. And I think, there's anything else from anyone else before we wrap up today? All right. Right.
Dr. Boyce, I see someone puts in the chat box to also explore the 800-4448 HIV helpline.
Thanks, Mary, for that. We do that as well. All right.
Most welcome. Not a problem.
Okay. Well, again, I think that's our time. And again, thank you, sir. Thank you for your participation. It's been a very good conversation about the case. I hope the didactic was helpful for anyone. If any questions after the event is over, if you have any ideas afterwards, you can always email me or Conrad. And that's it first. This is our 78th episode. I feel like I sound like a TV producer. A 78th episode of MRFH Echo. It's Dr. Boyce here saying goodbye. Be safe and be well. Watch out for the weather, please. Be safe. Don't drive through floodwaters. We shall see you in 2 weeks' time. Take care, everybody.
Thanks.
Thank you. Thank you so much.